I'm Diane Holzer, the chair of the Advisory Council. I'd like to remind everyone to please turn off your cell phones or set them to silent. This meeting is being webcast. If you'd like to provide public comment, please fill out a speaker slip in the back and give it to Mrs. Moriarty. Mrs. Moriarty is right over here. Yeah. MAC members, as a reminder, during today's meetings, we have to actually say at the beginning of the meeting, at the last minute notice, we found out this morning that we actually don't have a quorum this morning. One of our members wasn't able to make it. So we'll be able to do our meeting, we'll be able to do discussion on items, but we will not be able to take any action or vote. So I'm sorry for that, but it was something we just found out this morning. I'd like to now call the meeting to order, and Mrs. Murray, please call the roll.
Ms. Abe?
Present.
Dr. Adams?
Present. Present.
Ms. Brelia? Ms. Dugan? Ms. Perez? Ms. Holzer?
Present.
Thank you. We do not have a quorum.
I only have one speaker slip up here right now. If there's anyone else wants to bring one up, you can do so during the meeting. Oh, looks like there's a hand in the back with another one. The first one I have is from Carrie Sparabon. Oh, you want to wait for your agenda item. Okay, sorry. Any other public comments from the audience? Faith, are you wanting to do yours right now? No. Okay. I'm sorry, Faith, we can't hear you. You're facing the other way.
She said she's still filling it out.
Okay. And I have something else from Rachel Fox Tierney. Do you have a public comment?
Item's not on the agenda. Not on the agenda.
Okay. All right, I am going to move to, unless Faith, is your comment on the agenda or not on the agenda?
You don't have to complete the speaker slip, so we're ready for comments on items not on the agenda.
For the record, my name is Faith Gibson. I'm a licensed midwife, and I represent the California College of Midwives, but my comments have to do with mothers and babies and midwives and nothing political from that standpoint. Recently, I became aware of the really high level of that in proportion-wise of how many maternal deaths are actually happening after the baby is born, 52%. Only 17% have to do with childbirth itself, 31% during pregnancy. And that our midwifery licensure as it currently stands is ends at 6 weeks, except for what's kind of vaguely referred to as interconceptual. But we don't have any direct authority to provide postpartum care for the first year, which is what all of the statistics that we have for maternal mortality are all based on that whole first year, not just for the first 42 days. And also that, sorry, I derailed myself here. That our current licensure ends our technical responsibility, which would also have to do with being employed in any kind of situation where you were providing postpartum rather than prenatal or interpartum care. And so I believe that it would be appropriate to seek an expansion of our standard of care that matched with the World Health Organization of 1 year, so that we were able to provide care to women through that first year, that would be accompanied by an additional educational unit which would deal with what the dangers are in that first year. Apparently, for some reason, somewhere around 5 months is a big time that postpartum mothers die, having to do with cardiopathy and things of that sort. And then there's the really intense issue of postpartum depression that ACOG recently has actually added a 3-week office visit as a postpartum in terms of postpartum. It used to just be 6 weeks, now 3 weeks. But a lot of the women have reported that that's basically kind of a 10-minute check-in, weigh-in, blood pressure. They don't really feel like when you consider you had to hire a babysitter to get there, that they don't feel that that's really meeting their needs. And certainly for a woman who's depressed, A, she probably wouldn't make her appointment, and B, you wouldn't catch it in 10 minutes, especially if you're dealing with a mother that you haven't seen during the pregnancy, that there's a different level of recognition that happens when you're dealing with someone that you've known from prior to that moment. The other horrible statistic having to do with postpartum maternal deaths is the suicide rate is apparently 3 times higher than the rate for medically related maternal deaths, and that I believe that if our scope of practice was expanded, that we would need some additional education in the areas of recognizing cardiopathy, any signs or symptoms of cardiopathy, dealing with depression, and having creating connections in the community so that you have some place to send women who need services in either of those arenas. And also that this were the scope of practice for California licensed midwives to include that whole first year, that would actually allow midwives to be hired by places like Kaiser to do home visits. The World Health Organization, I believe that their recommendations are, I'm not sure if it's 24 or 48 hours, but there's basically a home visit or a visit of some sort at the equivalent of kind of like 2 days, another one at kind of like 4 days, and then one at 2 weeks. That kind of matches what most home birth midwives do. We see mothers somewhere in that first 48 hours and then the second 48 hours and then at 2 weeks. I and a very few other midwives have expanded that to include, so there would be a 2-week and a 6 weeks visit. I do what I call second 9-month care, and I've known other midwives to do that, which is that I give the mother the option at the 6 weeks visit to come back at 3 months, and then again at 6 months, and then again at 9 months. And I certainly could include a 1-year visit if we were to do this. Any questions? No, thank you. I guess that's it. I'd like to see the medical board approached with the possibility of sponsoring a bill that would allow us to provide care for a longer period of time for the entire postpartum, and that would allow us to be employable within the system. I actually think that if midwives worked with obstetrical providers in that postpartum arena, that we might actually kind of start to figure out how to actually work with each other to not kind of each side seems to sometimes demonize the other because we don't know each other on a personal level. So I see another benefit to it from that standpoint as well. Thank you.
Thank you, Faith. Great idea. Rachel, did you want to? Yeah.
Rachel Fox Tierney, licensed midwife. And actually to follow up on that about communication. So the issue that I wanted to bring up is the medical model of care that still does not know what we do and who we are. So it came to light recently at a transfer of a preterm labor into a hospital, and I was asked, and I haven't been asked in a long time, who my backup was, and also that was part of the issue, and then that the physician then also went on to say that they could not continue to care for this person because that would be condoning home birth. And we got discharged, but fortunately she was able to find another provider. But this physician also thought that I could provide the medication that she was prescribed. So there clearly is a need for communication and education so that they know what we do, and that we're licensed, and that was the other thing, that I'm not a lay midwife. Thank you.
Absolutely. I agree.
That sounds like an EMTALA violation that you might consider reporting.
Okay, I'll talk with you,
EMTALA violation, emergency medical care. I don't believe the physician can refuse to care for the emergency.
It was the follow-up care that they refused.
I think if it's the same issue, it's not allowed.
Yeah,
I believe. I believe.
Yeah, I
Okay,
believe them.
hold on now.
So, yeah, no discussion.
Okay.
So, so follow-up to what Rachel said is that CALM has developed a program and a presentation, much like Smooth Transition does in Washington State, to take into hospitals to improve collaborative relationships and do cross-discipline education. And so CALM would like to request of the MAC to ask the medical board to collaborate on such a project. I don't know how that would get done, but it would go a long ways if we could have multiple stakeholders be involved in such a project to improve transfers and outcomes.
Are there any other comments that are not on the agenda?
Can I get 2 bites of the apple?
No.
Yes? No? Okay.
Nope. Each person gets to do one public comment on items not on the agenda.
All right,
You can slip it in there somewhere, I'm sure. Okay, moving on to agenda item number 3, approval of the minute. Oh, we can't approve minutes either, can we? Are there any corrections that anyone has for the minutes? All right.
Oh, right.
No, but it would make
You just were
our
curious.
lives a little
Okay.
easier to do it now.
If there are corrections to be made, then if they're approved with those corrections, then the corrections will occur.
Doesn't it help staff to know what they are now?
Yes, it does.
I have one correction. Page 3-4, item 8. Ms. Dugan noted that the California Department of Public Health Licensing and Certification Branch has been processing, that should say processing birth center applications.
Okay, so I just have a question. The first page of these minutes says that Ms. Dugan was absent, which I believe she was. So how is it she made comments on page 3?
It's her report. I read her report.
Oh, you read her report?
Yeah,
Okay,
yeah.
thanks.
Are there any other corrections? Okay, seeing none, then we can move on to agenda item number 4. Report from the chair. And I don't have much to report. In this last quarter, I attended the medical board meeting in Sacramento. I always learn a lot of things when I go to the medical board meeting. It was pretty interesting this time. The work of our task force are ongoing. Some of them are moving forward and doing good work, and others need a little breath of life, and I was hoping to be able to do some of that at this meeting, but I guess we'll have to wait. We need some new members on some of our task force. The complaints regarding Social Security numbers and birth certificates seem to have slowed down, and I'm not sure if there really are less problems or if midwives are just not getting in touch with me as much about the occurrences of those things, and I do look forward to what Ms. Simons has to report on that issue. Generally, I haven't heard a lot this quarter. Midwives, as always, it seems to go up and down, have intermittent problems ordering medical supplies from various medical supply companies, and it gets fixed for a while and then it gets broken again. But that seems to be a major obstacle for midwives in general as well. And I think that's all I have. I communicated with Jocelyn in this last quarter. She sends her regards, and she's hoping to be able to be with us for our next meeting. So that's it. With that one, any questions or comments on the report? Seeing none, any public comments? Moving to agenda number 5, a report from the task force regarding challenges of obtaining Social Security numbers and electronic filing of birth certificates. Ms. Simos.
So I just wanted to provide an update. Ms. Webb and I met with the CDPH's Center for Health Statistics, which oversees our Office of Vital Records. So it was the person at the head of that center, along with staff from the Office of Vital Records. We kind of we had sent those examples that I've received from some of the members of MAC on the troubles that people are having and the concerns. And the meeting was really to talk about the possibility of midwives electronically registering those births. And so when we met, basically they pointed to 2 sections of law in the Health and Safety Code. And one is 102-400, which basically says each live birth shall be registered with the local register within 10 days. And then 102-415 of the Health and Safety Code, which basically talks about births that occur outside of a hospital or outside of an alternative birth center, and who can register those births, which I'm sure you know it says the professionally licensed midwife in the attendance of the birth, and that they have to register that certificate with the local registrar. And so basically they said that CDPH really can't tell local registrars what to do, because we had asked, is there any possibility of maybe first of all, they said it would be impossible for a licensed midwife to register from their home or their office, because the requirements are that they have to have a lot of security kind of stuff, similar to what a state agency has to have. So it has to be, I'm not an IT expert, but firewalls in place and security enhancements that would be very hard for an individual to have. And so me and Carrie, Ms. Webb and I tried to look into some other opportunities of maybe with those local registrars, maybe have a day or 2 a month that they could have a computer available for a licensed midwife to register on their system. And basically they said that was up to each independent local registrar, that they couldn't tell a local registrar that they had to do something. In the past, a long time ago, when I first started with the board, 10 years ago, this issue came up, and we had met with CDPH, and at that time they had done monthly meetings with all the local registrars, and they had said that they would bring this up in their monthly meeting, encourage local registrars to work with midwives and remind them of the law. But apparently meetings like that don't happen at this time. And so we kind of asked different questions to see different ways that we could try to facilitate some help from our sister agency. But it was basically these are the laws, and really what midwives should be doing is working with their local registrars and creating relationships with them, and so they can kind of work with them in a more cooperative manner. But CDPH really isn't willing to facilitate that. And so Carrie and I did, like I said, we tried to ask some questions to try to get some kind of collaborative thing going. But Carrie, do you have anything to add?
No, there were a lot of people in the room, and we were
25 people in the room, and me and Carrie.
There would be some,
and the meeting was 10 minutes.
Right.
So
power there
yeah.
to do something, and we
Right.
brought up that this is something that may be impacting communities of color more than Caucasian applicants, and to see if, that would get their attention, that this is something that would be viewed negatively if they couldn't assist. And again, they emphasized that it was not
Their role.
their
really.
role to tell.
They don't have
local
oversight.
entities
They
what
can't
to do.
tell them what to do. So we did try to come up with some possibilities, but it doesn't. They did. They acted like they wanted to be collaborative and proactive. So they did. I know we kind of talked a little bit before Social Security. That's kind of a different issue because it's federal, although they have local county offices. It's a federal, and they said the same thing. They have no control over Social Security, but they did give me a contact at Social Security, at the Social Security Administration. She's the public affairs specialist for the northern area, and I have her telephone number and email address. And they said, maybe she could help address issues the Midwives Association may have with the Social Security Administration. So I do have that contact. I can pass it on to the MAC. I can pass it on to Rosanna. But we really tried to think of like outside the box. But it's just because maybe in the past it was more their role to provide guidance, even though they didn't have control over what they did. That they had more like of a guidance role, which it doesn't sound like exists today. They don't have those meetings anymore, and basically they're the registrar of births, and they get that information from the local registrars, and that's kind of their role. And so, sorry that I don't have something more positive to report, but we tried.
Thank you for
Yeah.
trying.
Well, I turned my mic off. Thank you for tackling that problem. As the case with everything concerning midwifery care, there are tons of barriers, so let's keep swimming.
Question? What did they say about automatic enumeration of the Social Security? Because that's something they could do at a state level.
We didn't bring that up. We were talking about like what's the possibility of midwives electronically registering the birth. So that's where.
I could see that needing a statutory change, sure,
Right.
yeah. So feel free to reach out the next time if you ever get such a stakeholder meeting. I'd be very happy to try to be there too.
Yeah, it really wasn't a stakeholder meeting. It was a meeting between two state departments. And so I was asking, another state department to meet to discuss the issue. So we don't usually invite like outside non-state agencies. So if it were set up as like an interested parties kind of thing, then we would send a notice out like we usually do for interested parties to our subscribers, MAC interested parties. But this was really like us asking trying to collaborate. And we do it in a lot of different issues with CDPH. Opioid prescribing, our enforcement-related endeavors, like the death certificate project related to opioid deaths. So we work with them on a lot of different issues. And actually, I work with this same group and the same doctor that oversees it on other issues as well. So we do have a very collaborative relationship with them on other issues. I just feel like on this one, they don't really think that they have the ability to tell the local registrars what to do. So,
On a related note, recently got a hold of someone at CDPH on the issue of Los Angeles County requiring a letter from a physician in order to register a home birth and verify that it was a live birth. And they acknowledged that the County of Los Angeles didn't have the authority to be asking for that, and so they're going to be correcting that. So maybe you can tell me who to follow up with about the automatic enumeration. I can see if I can make any headway there.
okay, sure.
Thanks.
I can let you know who we met with.
Well, interesting that they could, in Los Angeles County, they could tell the local registrar what to do, but they can't.
I
Other
think
ones?
it sounds like if it's in law, they can probably say you're not following the law, but this is an area that's not in law. And
Right.
so they can, I think that they would be able to provide guidance like you're not following the law, but like, oh, you should work with midwives and you should provide them a computer or help them electronically register. That's not in law. So if there were a statute, right, that required this, then they would have to, follow and make sure that the local registrars are following it, but there's not a statute in place. It's basically us asking them to collaborate with, with us on this, so.
Well, it's what's curious to me is that, and other midwives in the room, correct me if I'm wrong, but the several counties that I've interacted with in terms of getting birth certificates all use the same out-of-hospital birth handout that the state prescribes. Like, it's coming from CDPH. You get it online. All the counties are using that, so I don't really understand how they say they don't have any right to tell the counties what to do if they're prescribing what the procedure is for getting a birth certificate if you had an out-of-hospital birth.
Right, because I think that's, they can, I mean, I can't speak for CDPH because I can only tell you what they told us in the meeting, but they can say this is a process to get it registered with Office of Vital Records, right, because that's CDPH. So here, county, this is what you need to do to get it registered with our office. But as far as like being more collaborative with midwives and, allowing them to electronically register, that's not something that's existing law.
But they're already dictating what the counties should ask for.
Right.
So what I'm hearing is they didn't want to play ball, really. I mean, like, they weren't going to go there. They didn't want to try to solve that problem.
Each county has their own interpretation of, in fact, they print out different interpretations of the state guidelines. Yep.
The little,
Okay.
are you talking
Yeah,
about
the
the
packet.
packet?
This is
So it
a
looks
strange
different in each county?
dynamic.
Oh.
You can make a public comment and then.
Got it.
Okay. Well, thank you very much, Ms. Simos, for that. I guess we're just kind of left with our problem. We'll have to work at it from a different angle, I guess. Any comments from the MAC? Nope. Okay. Then I guess we can move on to agenda item number 6, establishing goals for the Midwifery Advisory Council. I don't think we have any new ones. I liked, maybe we could put it on the agenda for next time, Rosanna's suggestion about working with an educational component at going to the medical board and seeing, maybe we can discuss that next meeting as a possible goal for the MAC. We aren't totally moving forward on the goals that we have yet, so I think we should just hold our own unless, does anyone on the board have any goals that they want to add at this point?
No, we're good.
Okay. Then seeing none, any comments from the audience on that, on goals, establishing goals for the MAC?
Well, Faith Gibson, I'd like to ask that you consider the expansion of the scope of practice for licensed midwives to include the first maternal year.
Okay, we could put that on the agenda for next time to discuss. Any other comments? No. Seeing none, we are going to move on to agenda item number 7, report from the task force and discussion regarding the data collected on the licensed midwife annual report. Mrs. Abe.
don't think that much is cut off. We'll just give it a shot. Okay, I'm ready to give my report. This is on the demographic data, the licensed midwifery annual report. My name is Danielle Abe. I'm a MAC public member. I'm also a professor at Sacramento City College for the Community Health Worker Program. And I'm a midwifery consumer, having 2 home births that were wonderful. So what I like to bring forth today is just a brief report. I have some examples to present. I would like to discuss the impact of the demographics and make some recommendations. So currently, only county data is reported as a demographic. So all of the counties where births take place are reported. Here's a quick example of how the licensed midwifery annual report looks. And then the data is in rows by county. I would like to say this is actually good and important because you can see, like Alameda County has 226 births, and then you can see the outcomes. So if you're in policy for Alameda County, that would be useful for you. So other data, if you go over the reports can be found at the medical board website. And if you click midwives, and they're on the front page, and they're going back about 10 years. But it's all public record, so you can get that data. You would see there's no demographic data for ethnicity, religion, age, and so forth. So I just like to review the Business and Professions Code 2516. Of course, I'm not going to read the whole thing. It's in your packet under 7.1. And so part of it says, letter G, the board with input from the Midwifery Advisory Council may adjust the data elements required to be reported to better coordinate with other reporting systems, including the reporting system of the Midwives Alliance of North America, while maintaining the data elements unique to California. To better capture data needed for the report required by this section, the concurrent use of systems, including MANAs by licensed midwives, is encouraged. So the key points for that code 2516, data may be changed. And the second point, why? To better coordinate with other reporting systems. So that is a very important point. And when we think of systems, that would be a question to ask. What systems should we coordinate with? I think the public health database for the whole state of California, licensed midwifery, the statistics aren't as coordinated. So that's a conversation that is important to discuss. So let's talk about what current data is collected in California hospitals. So a ton of data is collected when a woman has her baby in the hospital. There's practically nothing that is not known about her habits, sex partner, like everything they could find out is found out. And so there are a couple of other agencies, but this CMQCC, they actually collect live data and live outcomes. The best word they use is real time. Its data is collected in real time by the hospitals that participate. So you could go to this CMCQQ. They have some demos of the data. And I think I put in an example. Let me see. Okay, an example is on Exhibit 7.8. And you can see this is just a demo version, but it shows you the ethnic breakdown. And they collect a ton of other things. So what else is collected from these California hospital databases? And it's public record, so March of Dimes pulls the information and they make a ton of reports. They're quite fascinating, so I included them in your packet. So here's a snapshot. This is a week in California. 9,514 babies are born every week. 587 are born to teen mothers. 3,161 are delivered by cesarean, 839 babies are born preterm, 649 babies are born low birth weight, 45 babies die before the first birthday. And I don't have access to the computer just sitting here, but if you're in the room, you can go to 7.5 exhibit. You should have that, or it's in the back. And there's just more information. So it talks about prenatal care, gives you more information on the different types of how classifications of preterm birth and for mortality. The next page talks about, it's a racial breakdown and an age breakdown of all of those births. So for example, if you have the handout, you would see Asian 14.7%. Wait, I'm sorry, I might not be reading that right. Okay, I'm not going to quote that. You just need to look at the paper because the lights are off and it's really difficult to see that. Okay, what else is fascinating about this? Page 7-7, it gives those markers that public health makes a lot of decisions on: preterm, low birth weight, infant mortality. I'll be coming back to those, and then they have little asides to give you extra information on that. So there's so many conversations and discussions just looking at that data. So data is important, it's essential, and I can use a whole bunch of other adjectives. You cannot underestimate the power of this demographic data. Here's an example of that March of Dimes report, and it's broken down by ethnic group. So you can see the California preterm non-Hispanic white is 8.3%, non-Hispanic black is 13.2%, and then Hispanic was 9.6%. Low birth weight 6%, non-Hispanic for non-Hispanic white, non-Hispanic black 11.5%, Hispanic 6.2%, and then infant mortality 3.9, non-Hispanic white, non-Hispanic black 9.3, Hispanic 4.6. So just by looking at that data, it's a conversation starter. You can see that by race, some groups do really good, and then other groups, it's not a good story, and there's a lot of heartbreak going on. So I like to give you another example. This is from the demo from the Midwives Alliance of North America database. You just go to their website. It's not easy to find, but just play around with it and you'll find this demo form. So they collect date, birth date, state, county. I like the education, 8th grade, high school, college, bachelor's degree, master's. They have many racial groups, not just 5. Chinese, Filipino, Japanese, Korean, Vietnamese, Native Hawaiian, Samoan, Spanish, Hispanic, Latina. This is the rest of the form. They also include a question about religion, Amish, married or partnered, Medicaid, WIC, and some other questions about what type of insurance. This is valuable information if you're at a policy level when making decisions. So I'd also like to bring up some examples of data that is currently collected from the California Board of Nurses. And they are collecting gender of the nurses, age group of the nurses, nurse midwives, I'm sorry. They do collect this for nurses. I wanted to point out what they're collecting for nurse midwives as an example. And they also collect racial group for the nurse midwives. There actually is no data currently being collected for the licensed midwives, but this report, the full report, is in the packet on 7.3, that they extrapolate some information for licensed midwives. So now let's talk about the consumer impact. And this is data that's pulled from the California 2018 Licensed Midwife Annual Report. And so it reflects, with the data that's there, 3,538 live births are reported, and 391 licensed midwives. They're reported by 391 licensed midwives throughout California. So on that one report, this is for the entire state of California, there were 13 preterm births. And if you break it down by percent, that's 0.003% out of those births attended by licensed midwives for that year. 13 low birth weight infants, which is 0.003% for that year. And then just because we're in Sacramento County and I live in Sacramento County, I would like to give you those numbers. There were 117 births delivered. There were 0 preterm births. There were 0 low birth weights. There were 0 maternal deaths. Those numbers are so amazing. So if only we knew the demographics, that would also be very helpful. Additionally, 151 statewide completed VBACs, 341 cesarean births, which breaks down to less than 10%. That's a good number. There were 0 maternal deaths statewide for that year. There were 5 infant deaths statewide. Okay, so this is an example of data from the county, and you see this is just looking at preterm birth, and that year starts at 2013 through 2016, and then they break it down just looking at black-white numbers, and you can see the difference. There's a stark difference between the African American and Caucasian. But I just want to give you an example of the power of data. And so if you're a policymaker, if you have some funding, and if you need to know how to make decisions, how to help your community, you have to have some data that looks like this. And it already does exist, but just for the general maternity health care system, but not for licensed midwives. So why is that data important? Even though we don't know the ethnic or demographic breakdown, racial demographic breakdown, let's just assume 5% of those families served by are African American. Then if demographic data was available, it clearly demonstrates that maternity care by California licensed midwives is saving Black lives. So I just think that's important to point out. It's only an assumption, but I myself was cared for by midwives. Of course, that data is not collected, but what if it was? I think that's why I'm sitting at this table, because I wanted to say, like, what if we had this data? Then some of the issues that are brought up in the public comments, we could probably address them more, because more people would pay attention. If you look, do I have my next slide? Oh, this data is convincing to impact maternal infant health disparities. Oh, I don't think I have the next slide. I want to go back. Oh, really, I just want to look at these numbers. You have to compare. The numbers were 0 in Sacramento County for preterm birth, care by licensed midwives is 0. And then, of course, other care, it's much higher. So that's a conversation starter if we can get access to this demographic data. So the impact, demographic data can impact policy and increase public funding. It will also, if we have access to this data, it can increase access to midwifery care for California families. And that means, since if you do put some cost onto the care, the price of care by a midwife, we know most families have access to Medi-Cal. And so when you talk about what would save the state money, and based on outcomes, if we had that report, like if we really knew, I can only guess, but I'm just saying, say a midwifery birth is $5,000, birth at hospital is $7,000. The state wants to save money, and we have data to show that care by a licensed midwife for African American family, better outcome, cost savings. Then you're going to see some movement towards the use of licensed midwives. So, and of course, not of course, but that would definitely impact African American birth disparities for all families, but in particular, I do bring up African American birth disparities because they're the highest. So here are my recommendations. The minimum and this is for consumers, if we can add the California hospital demographics. They're already being collected, so if we don't want to do too much to start, just do those basics: Hispanic, non-Hispanic, white, non-Hispanic, black, Asian or Pacific Islander, others. So that's what's currently being collected. What a minimum revision for midwives, this is already being collected by the nursing board: age of nurse midwives, ethnicity, race, and gender. However, I will give you my optimal revision. If you can use the MANA demographic data, it's on page handout 7-4, what they're collecting. And I want to just point out, actually, I am African American. My children are African American and Japanese, so they don't fit on the data collection form. And so that's a conversation that should be had. But, you know, we got to start where we can. I just like the MANA because there are more options for people to select from, and that's good. Secondly, we should add California Nursing Board demographic data for midwives, because it's important to know where are the different types of midwives. We could just only guess, are there Native American? You know, we don't really have any breakdown who are the California licensed midwives. So that's actually, I think, unfortunate. It's important to know who they are demographically and how old are they. So if we knew their ages, then we could plan, and there might be more movement for education of younger midwives. And I would just guess that I don't know, I actually don't know. So that I would just leave it at that and say that's a good conversation. Is the midwifery force skewed at an older age, and is there not enough younger midwives coming in, or women of color, or so forth and so on? So my recommendation is to adopt some form of revision, and if it could be implemented in time for the next cycle of reporting for the licensed midwives annual report. And keep in mind, what is valued is counted. Are there any comments or questions?
Any comments from the members, from the public?
Thank you. That was an excellent presentation, and useful. Thank you.
Oh, thank you.
Yeah, thank you. That was very well done. So one other place that we could be collecting better demographic data would be require a statutory change for planned place of birth on birth certificates. The Department of Healthcare Services Vital Records Division has made a recommendation that get done, and but they're claiming that a statutory change is needed. So then we could be integrating our data with the hospitals, as well as, I mean, that's all the information that, for instance, March of Dimes, that's where they pull their information from. And whenever midwives submit birth certificates, we're giving all that demographic information on the birth certificate. So.
Hi, my name's Tisa. Thank you so much for all that data. That was very interesting and enlightening. In my community, where we serve about 50% of our clients are African American, this data is extremely important, especially since there are many county, and I am speaking about LA County right now, county funds being pushed in this direction to improve Black maternal health. So if we did have these numbers, if we could show that we're really making a difference as licensed midwives in our maternal outcomes and babies, and healthier babies, we could push a lot more of these funds towards programs that are supporting this kind of project. So thank you.
Madeline Weissner, I'm a licensed midwife. I agree that collecting more information is really obviously very important for a lot of reasons. I logged on to the MANA stats few nights ago to try to put mine in, and the way that the questions are asked of us is extremely confusing. And I have a good grasp on like data collection and research techniques, and I know that if other midwives don't, they would be even more confused than I was. Not only does the LMAR like fail to ask really important questions like payer, bare minimum, we got to know who's paying for the births, right? Especially if we're wanting to improve access for Medi-Cal families. But like there are questions where it doesn't give you an option of saying that you transferred care because a baby was transverse, you know? It gives breech or vertex. Doesn't give options for if someone is in preterm labor and you transfer them before they give birth. The numbers that you referenced were preterm births out of hospital, not total preterm births, you know, which are probably comparable, maybe a little lower than in hospital, but we don't know because it doesn't ask. I was really excited when it got automated, like TurboTax style. I thought it would make it a lot easier, but I've been stuck halfway through. So I look forward to the tool asking more questions, but also to the tool being made better, honestly, so that we can get accurate information.
So, I'm sorry, I'm a little confused. You started off talking about Manistats, but most of what you've been talking about is the LM.
The LMAR.
Okay,
Manistats
okay,
is
good.
dead. You guys know that, right? Like, they're not doing anything with the information anymore. The system that they used was super outdated and couldn't basically find researchers to work with it.
Well, that's
anymore.
not true, but that's not what we're discussing right now.
Manistats collects really valuable information that the LMAR doesn't. And I would like
Well, we're
to get more information.
restricted to the data we can collect unless we make a legislative fix. We can do small adjustments, right? But we can't add anything big.
Can't
You're
ask for
shaking your
payer?
head. We can do whatever we want.
Seems like it's at a minimum.
Okay, I'll provide some clarification.
Thank
here.
you.
I'll let Carrie address that, but when I read it, it looks to me like we can add whatever we want as long as we keep what's already there.
Yeah. So if we're able to tweak the language that's already there, which is how we did the most recent revision. It's incredibly expensive. That cost like $90,000 to do the last revision. I mean, it's hugely expensive to reconstruct and maintain the LMAR. For these additional terms that are not already provided for in any way in the statute, a rulemaking would be necessary. And so for that, we have to see actual proposed language that factors in how the questions are posed, what the options will be, and there are 6 regulatory requirements that would have to be demonstrated from necessity, authority, consistency, and some others. Part of this process would be reviewing the impact to midwives in collecting the information, changing their forms, reporting the information, and it's probably a negligible cost, but it's something that has to be worked up in the rulemaking. And then the other thing that has to be considered is whether in some of the smaller communities it would make the patients identifiable. So these are things that have to be thought about when we proceed with considering this rulemaking. But the big consideration is that this would be expensive, and that has to be addressed in the rulemaking and would have to be approved by the board. So I just want to point that out. I think that it is possible to add additional items, but it has to be through rulemaking. We can't just plug it in.
I think then that, to me, I know we can't vote on anything, but that's still important move forward, because I'm still in shock that this is so obvious. This data's been collected for like 50 or 60 years that I'm surprised it just wasn't brought up before. So that's unfortunate, but I think, I don't know how you get funding, but I mean, there's the maternal health disparities are so desperate that there could be funding to just change it, if that makes sense. I don't know. That might be a wish list, but it would be important to change, because with that data, you could make the case that you're saving people, you're saving babies. So that's just how important it is. So I just feel like, great, let's understand the process and let's move it forward, because at the bare minimum, it's important to know who are the midwives so we can get more midwives, and who are the people that are being served.
I do want to say that because of the rulemaking process that we have to go through right now, it can be faster to go through a legislative change, and anyone in any association can bring forth these ideas to the legislature to add those in. And so, that could take a year, whereas rulemaking, it's taking, 2 years to, if it's successful, to get through.
So if we just wanted to add just even the Hispanic, non-Hispanic white, just those few things, we have to go through a whole rulemaking thing to add just that one little piece?
Yeah, we would have to do a rulemaking to add those.
I didn't realize that. I thought if we made one small tweak that we didn't have to go through that, but we do.
There's nothing like that exists in the statute.
Okay.
So what does the may adjust data means?
We adjusted the data elements that were already being collected, not adding.
Could you give me an example?
Sure. So. The number of women, Nat actually worked on this in depth.
So your question is, what are the enhancements that were made to the original revision to the LMAR or to this last reporting period? What was the question?
My question is, what does may adjust data elements? What does that mean?
Well,
is that like moving a comma or a period, or adjust? Like, what is the definition of adjust data elements?
Well, and I'll let Carrie maybe define that, but I can tell you some of the changes that were made from the previous system to the new revised system was to enhance some of the data elements that were collected, such as VBAC information. Previously, the report asked how many VBACs were completed. In this case, we asked how many were planned VBACs, how many were completed VBACs. Of the VBACs, we added additional information for the client. Was this your first VBAC? How many prior cesareans have you had? How many prior vaginal births have you had? So we just extended out a little bit on the questions that were already being asked to get clarifying information on those data elements. In addition, we added additional outcomes, reasons for transfers. We clarified some of the possibilities for the transfer information. Instead of having midwives select other because that value wasn't available, it was with working through interested parties meetings and the MAC, options to select were determined, and that was added into the system. But there wasn't really additional data elements outside of what was originally in the LMAR system. It was just clarifying questions on the existing data elements.
So
that-
an example would be, it asks for the number, reason, and outcome for each urgent or emergency transport of an expectant mother in the antepartum period. Those were expanded out. If part of the statute said, demographic information for the midwife and the mother, then
Then you could adjust
then
it.
we would consider that something where it would fall into that can adjust data elements. But here we'd be adding an additional requirement that's not already identified in the statute. And to require it, there has to be a rulemaking. Otherwise, someone could say, it's an underground regulation, it's burdensome, and file action against the board for that.
I see. Thank you.
Hi, Carrie Sparrowvon. I just wanted to provide some historical background for people that are in the room that weren't sitting at the table when we created this imperfect LMAR. Number one, we didn't have anybody with really any knowledge on this kind of data collection working with the team that created the LMAR. We had input from interested parties like California Association of Midwives, MANA, California College of Midwives, and ACOG as well, and we tried to come up with a data set that would work. To do it over again, I would have given input when Faith and I were helping the legislature actually write the statute, that we would have people on the team implementing the LMAR and writing the questions, knew what they were doing in terms of creating questionnaires to gather data, because none of us had that knowledge. And so it, from the beginning, was going to be an imperfect tool. And we've tried to make adjustments as we've gone along, but we still don't have those people as part of the team to write the questions in ways that make it easy for midwives to answer them, and that have thought about all the possible variables, that have looked at everything that you brought up today, which is fantastic. And, if we had the money, it wouldn't be that big a deal to write something that actually worked and included all the data elements that everybody else is collecting. But there is no unlimited budget. And I think Ms. Webb's suggestion that we go back to the legislature, and I wouldn't actually ask them to, we want this, this, and this in it. I would say, ask them for something that says, we want the same data collected that's being collected at the hospital level. Those are the data points we want. And so that it can be fluid as we go forward. So if the hospitals decide to add something, we don't have to go back to the legislature to get a statutory change. We could just change it within regulations. And it'll be clear that we have that authority to do that. And working in the bureaucracy of government is always a slow process.
I thank you. That was a wonderful comment, because we are a committee of the medical board, and the medical board already does this, so it's completely possible. They already have a template. So they don't, I think they do, because hospitals.
We don't
No.
license or regulate hospitals.
The hospitals do it. It doesn't have anything to do with the board. If it did, we'd have a good tool to begin with.
The board regulates doctors.
Somebody is required to collect that data. It doesn't just happen. The data that's the CMCQQ.
But they're just a non-profit organization. They don't have legislative authority.
Right.
CM
Well, counties have data. Okay, I'm not the guru for all data, but I know that there is a standard. People do it as possible. That's all. That's actually my only point. It's completely possible without. There is a system that is functional.
You're right. Our
Okay.
system has never been directed to interface with that system.
This is going to be a problem for the webcast.
Sorry. Rosanna? Or I don't know who's here first.
As far as I know, there are two major data collections going on for hospitals in the state of California. And that is through birth registration, and that's where a lot of the demographics are collected, and CMQCC, who is a private nonprofit. And we have inquired with them on multiple occasions to be part of that, and they claim that they're exclusively focused on hospital birth and quality improvement in hospital births, and that they don't have the funding to include us in any way, shape, or form. So back to, I think, one of the easier fixes would be planned place of birth collection with birth certificates. Then we could be getting a lot of that demographic information.
Faith Gibson, and this is just a historical comment because I was the person that sort of started the chain of events that wound up being the LMAR. And at one point I was actually standing in the room at a medical board meeting, and a lobbyist for one of the organized medicine organizations was berating a medical board member about how, why weren't they doing something, because we midwives were out there killing babies right and left and they weren't doing anything. And this person said, we don't have any information about the midwives. We have no idea whether or not they're killing babies because we only deal with complaints. And I thought, my goodness, why don't you? And so I talked to Senator Figueroa's office, Tim Marchant, about adding that. I think that already that it was AB 1638 that the Midwifery Advisory Council was already part of that legislation about adding it to that. But believe me, I had no knowledge of how you did, statistics on a more global scale. And so the focus was just so that, so that the public would know and the medical board would know, and we would be able to rebut the conclusions by kind of our detractors that some or another we were out there killing babies and nobody, we were getting away with it. So if you look at it from that standpoint, it's a pretty good thing. If you look at it from the standpoint of all of these other things to account for ethnicity and for the age, and it is true that things like to get the prematurity rate, we have to know how many babies were transferred, how many antepartum or interpartum transfers were specific for prematurity. I'm not sure. I thought it did that, but maybe it doesn't. I just don't remember. Anyway, I personally I would love to hear from somebody. Someone talked earlier that said she was confused about the information. I would like to figure out what it is that we're saying that is making it hard for midwives to figure out what information we want from them. So thank you.
So, Carrie, just as far as the next steps, if Ms. Abe comes to the next meeting, and I'm happy to work with you, with specific language about what we'd like to add regarding, what she just presented, we have a quorum, and we could vote on that, and then we could start the rulemaking process in order to add it. We wouldn't be able to add it, I guess, for the next year, because it will take longer than a year, you think, to do.
Right. And the items that need to be addressed are the 6 rulemaking
6 things.
items, which I can go over offline.
Mm-hmm.
The cost impact to the midwives, and the cost impact to actually
Do it.
redo the LMAR to add this
Right.
section. So that would have to be reviewed and approved by the MAC and reviewed and approved by the medical board to be able to then go through the review process at DCA and agency before it's even noticed for public comment.
Okay. Seems like if we could have Ms. Obey do her presentation to each one of these committees, it would easily pass. I would, but, yeah. So I guess we can, would you like to do that, to come forth to the next meeting with specific language and start that process? We can.
And I would need more details, possibly.
Yeah, okay, we can talk about that. Are there any other comments? No. All right. Thank you so much for that presentation. I think it really highlighted the need even more. Okay, where were we? Okay, we're going to move on to agenda item number 8, report from the Task Force on Medi-Cal related issues. So the people who were working on that task force were Jocelyn Dugan and Shemin Perez, neither of whom are here today. And I know that Jocelyn has been out of commission, so I'm sure she hasn't done much work with Shemin on that. And I assumed that she was going to be here this morning, so I haven't really gotten a report from her. So I think we're just going to have to table that one till the next meeting. But actually, what we're going to need to do at the next meeting is appoint new people who are interested in working on that task force. And it would be helpful if one of the people on that task force actually could take Medi-Cal. So I think we just have to put it to the next meeting, right? Yeah. Okay. So I'll do that. Questions or comments from the members?
Can we make comments on that?
Of course. You can make comments on anything on the agenda.
Okay, once again, Tisa Kareen, I'm a licensed midwife in LA County, and I'm a Medi-Cal provider and a birth center owner. And there are many, I don't know what Shemin or Jocelyn were working on, but I have been working with Medi-Cal for 2 years now, and we still, we need to keep pushing. It sounds like you guys have some kind of task force working forward, and I would really love to be a part of that in the future. We're really struggling with getting fair payment and getting paid, period. That's something that we're really struggling with, which I'm sure many physicians across the board are probably having issues with. I also work inside of an FQHC as a midwife, and there are lots of concerns with payment in relation to the kind of work that we're actually giving, the services that we're giving. They're not comparable. But we are making a lot of headway, as some of us midwives are getting contracted now with healthcare plans and with IPAs. So I see that, and there's some other midwives in the audience today that when we were talking about licensing for birth centers, we're at a dead stop with that kind of stuff as well, which is really, really frustrating. We really need to get a seat at the table with DHS and really explain why we're getting this circle around with CPSP providers being a requirement to get licensed when getting CPSP is a requirement for licensing. It's an endless circle that LMs are not allowed to be, as a birth center, we can't get licensed because we don't have a physician and we don't have a CNM. Those are the only two people who can get CPSP provider status. And we can't get the CPSP provider status without a licensed birth center. Mm-hmm. So were you going to comment on that?
Yeah, just
You can finish though first.
yeah, just finish.
Okay. Some of the other things that are challenging right now are that the average midwife really can't access Medi-Cal. That the cost to the average licensed midwife is very burdensome to have the the med-mal coverage, unless you already have a very, very active practice that can support this from the very beginning. The requirement, the amount of money is a lot compared to someone who's doing maybe 15 births. And then also just addressing the fact that we need to make sure that all births are covered and not just birth center births. Those are my comments.
Great, thank you so much.
Carrie Sparrowan. So the reason that midwives can't take CPSP is because AB 1608 dictated that we couldn't be CPSP providers until the regulation was adopted, providing a list of reasons for us to refer to a physician. And that list has not been created through the regulatory process by the medical board. And therein lies the problem. So without the list, there's no CPSP. And without the CPSP, there's no licensing of birth centers.
Quite a conundrum. All right, if there are no more comments about Medi-Cal, the Medi-Cal task force. Where are we going? Oh, sorry, I'm on the wrong page here. I'm going to move to agenda item number 9. Discussion and possible action on revisions to the practice guidelines for California licensed midwives. And Carrie, maybe you can just start this, since you really were one that was working mostly on it.
Okay, so I guess my first question, because people have sort of asked, is for you, Ms. Webb. What authority does the board have to post the guidelines? Where does that authority come from?
The board does guidelines to assist practitioners, including physicians, and these guidelines were stemmed from multiple interested parties meetings with the midwifery community, and they were reviewed and approved by the MAC and the medical board.
Right, yeah.
So they're not
I know the
a
history
statute
of
or a
it,
regulation.
but where's the legal authority for the board to post guidelines? That's what I'm looking for. Where does that authority come to the board from?
Well,
Does it come through statute? Does it come through something internal?
It's not. It's just the fact that we're the regulatory agency. So it's like, what authority do we have to post anything on the website? But why don't you give the presentation that you're going to give, and I'll have my comments.
Okay. So what I'm going to say rather hinged on the answer to that question, because I don't see global guidelines for anything else that any other profession the medical board oversees. Like, there aren't guidelines of practice for physicians, broad, overarching guidelines of practice for physicians. I don't see them for physicians' assistants either. And so people have asked me, so why does the board get to post these guidelines? That's why I'm asking the question. And there's a copy in the packet of my suggested revisions. However, after I submitted those and I started getting these questions, it seemed prudent to find out what is the authority of the board to create something that overarching for a profession with no statutory authority to do so. It makes it look like a regulation when it's posted on the medical board's website the way that it is. And we know that it came out of a regulation, it came out of a regulatory process that created a standard of care. But it is no longer reflective of a standard of care. And yet having it posted on the medical board's website the way that it is confusing to physicians and to the public because they think it is our standard of care, and it's not. So my recommendation at this point would be to remove it completely. It doesn't appear to me, from anything I can gather, that it is consistent with other guidelines that the medical board puts together for other professions. And it creates this confusion with the public and with other healthcare practitioners that if it says it in the guidelines, then we have to follow that. And there's no statutory authority for that. We don't have to follow anything in the guidelines. Am I right? I mean, really?
You don't have to follow anything in the guidelines because they're in the guidelines.
That's what I mean.
Ideally, the guidelines and the standard of care overlap. So the fact that they're in the guidelines does not create the standard of care, but they should be in the guidelines because it's been reviewed by the midwifery community and that there should be overlap between the standard of care and the guidelines.
But the standard of care isn't any longer posted on the website, even though the regulation that created it is still there. You can't get to the actual original standard of care on the medical board's website. You can get to the regulation that created it that also has the regulation for VBAC consent, but you can't, the actual standard of care document no longer exists there. So if somebody wanted to see that document, they got to ask me or Rosanna or Faith or somebody else in the community for the document, and that's not available then to the general public so that the general public could see the difference between the guidelines and the original adopted standard of care that was done through a formal regulatory process.
Right.
The guidelines as they exist today were only updated by the MAC, and then the full board was asked to approve to put them on the website. There weren't interested parties meetings or anything in terms of my recall for editing the standard of care to create the guidelines. We edited it as part of MAC meetings and went from there. We didn't have, I mean, maybe I'm remembering it incorrectly, but I don't remember any interested parties meetings to discuss the changes that we made, because the only changes we made were to bring it into alignment with AB 1308 changes so that it reflected the law rather than a midwife standard of care. And it has, as you know, become a huge issue because physicians reviewing LM cases are being given the guidelines as if they were our standard of care when they're not. And so that creates a real problem for midwives that are being judged by that.
Well,
and if it wasn't on the board's website, we wouldn't have this problem, because it wouldn't be available to give to anybody. All that could be given would be the standard of care that was adopted through a regulatory process. And then it would be clear how cesarean section was viewed by midwives prior cesarean. And that's a huge problem with the guidelines, because the original regulation that adopted the standard of care addressed VBAC in Part B of that regulation. And then we created the guidelines, but we never referenced back to that regulation that told people how to handle VBAC. And there's a sentence in the guidelines that says that we should not see women who've had prior uterine surgery. So anybody that didn't have the history would think, oh, well, prior uterine surgery, that's a C-section, so midwives should refer for that. It's an honest conclusion to come to, but it's out of line with the sequence of events that got us there. That makes sense. So my recommendation would be to pull the whole document until we can get some kind of clarity on what we're doing, and really we need to adopt the regulations that AB 1308 says we should adopt. No, I mean that's the real list, and we haven't done that, and so we're using a list that doesn't really serve the purpose correctly. So that's my recommendation at this point.
So you want to take out what we have with the strikeouts and replace it with just pull it totally?
My recommendation would be to remove the guidelines completely from the website, not use them at all because they've not gone through any kind of regulatory process, and start from there, and then let's craft the document that the legislature said to craft. The list of conditions to refer to a physician. And we may not be able to get there, and I recognize that, but at least then there's no room for somebody coming forward and saying, well, you got an underground regulation on the medical board website because you're calling these guidelines and you're using it to discipline midwives. I mean, that's a bad position to be in, am I right? I mean, we don't want to be there, but that's what's going to happen. Ultimately, there are going to be midwives that are going to be upset about that.
You would have to point out testimony, something hard that showed me that someone was equating guidelines with a statute or a regulation, because it's clear in the document itself that it's not a statute or a regulation. It's designed to be helpful for the midwifery community and other stakeholders, to give them guidance that's consistent with AB 1308, and to give them things to think about when they're doing client selection and retention, and to hopefully pair with standard of care, but it doesn't set the standard of care.
I think,
and that has been repeated many times.
I acknowledge that. However, there is no statement with the guidelines that says it has no force of law behind it. It isn't part of a regulatory process. It isn't the midwife standard of care. There isn't anything with that document that states that.
So would you like to add that? Like you could have put it at the top of the revision?
It is at the top of my revision that you all have. It's there. But I think we're in dangerous territory to continue to leave the guidelines on the board's website when they appear to an uninformed public to be our standard of care. Clearly, if physicians that are expert reviewers are being handed those guidelines by the deputy attorney generals for the cases, and they're saying, here, use these, then they're being used in a way that suggests they're a regulation. And if they didn't exist on the website, they couldn't be used that way.
So the prescribing guidelines for controlled substances for pain, those are on the board's website, and those are provided to expert reviewers, but they are also instructed that it does not set the standard of care.
But that's not being instructed with
would
reference to the guidelines.
I would have to see testimony that reflects that, because there's guidelines all over the place that help to inform and help the practitioners, but standard of care is different. If it wasn't, we could just go through the guideline and say blah 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 blah. But we have to have an expert for each quality of care case that testifies as to the standard of care. And yes, there should be overlap with the practice guidelines, but the fact that someone did, 3 out of 5 things on the practice guidelines and not all of them doesn't mean there's a breach of the standard of care. It should be helpful, but it doesn't control what the standard of care is.
It might be helpful if only licensed midwives were reviewing licensed midwife cases. However, that's not the case. So how is an hospital-based obstetrician supposed to interpret the standard of care for licensed midwives? They don't have any clue what the standard of care for licensed midwives are. And so then they're given this document called Guidelines for Licensed Midwives by the Deputy Attorney General that's doing the case. There's an assumption that then this is law. And I've seen their reports, and I know they're citing it that way. So how do we solve that problem? And to my way of thinking, the best way to solve it is to take the guidelines down, create the regulation that's real, go through the full regulatory process. Then there's no complaints. Everybody's had their ability to speak, to have their voice heard, and their the list of reasons to refer can be done in a proper way. When we created the standard of care, and Faith can attest to this, it was no easy chore. Okay? There were comments from midwives all over the state about what to include there and what not to include there and how to make that happen, and it took us over a year to do it. So it isn't logistically a good idea to have a document that used to be called the standard of care that's now just called guidelines, but is being interpreted by other care providers as our standard of care. And yes, there is lots of overlap. Okay? There's not a lot of stuff in the guidelines that isn't part of the midwifery standard of care in California. However, there are things that are now missing from that document that are still part of our standard of care that had to be removed because of what happened with the legislature. And the primary one of those that is the tenet of midwifery care is that we give good informed consent, and the woman has autonomy over her body and she gets to decide what happens. And midwives then can decide whether they're going to continue care or not. We lost that with AB 1308. And that's a sad thing. I'm glad we don't have the physician supervision anymore. But there's still work to do here if we're going to put forth a document that really identifies our standard of care. And physicians create their standard of care. And it's done through their organizations, the California Medical Association. For obstetrics, it's the American College of Obstetricians and Gynecologists. They create those standards, not the board. The board creates standards around very specific items like, delivering narcotics and things like that.
Right, but that's
not
the thing.
overarching.
The board doesn't create the standard of care around that.
Right, you only create the guideline, but it's not a guideline over all physician care. And my guess is if you tried to create a guideline over all physicians' care, it wouldn't fly. I mean, it wouldn't even get off the table because physicians would have such pushback on it. And all I'm suggesting here is that what we've done, and I was sitting right there with you doing it, was we created a guideline that was overarching over all of midwifery care, and we shouldn't have done it. And we should correct our error now and remove it and go back to what the legislature has said we could do and create that regulation with the lists of why we should refer.
Thank you. I feel like you've given us a lot of valuable information on this topic. So what I hear you saying is the guidelines are working against midwives. You want to know if it's possible to remove the guidelines. And I have a question. Where is the standard of care?
Well, that's the problem, you see.
I
Yes,
actually
we
have an answer to that in a minute.
We created the standard of care. Faith has copies
Yeah.
of it. I have copies of it. Rosanna has copies of it. Where it isn't on the medical board's website with the regulation that created it. That's where you can't find it. And that's, I think it's a problem. It's a problem that the regulation is still there in the first place if it really doesn't have any more legislative authority to be there.
So there's a document that is called Standard of Care for licensed midwives.
Yes, ma'am.
And there's
I'd
no
be happy
way,
to email it to
no
you.
way to incorporate that into these guidelines?
The guidelines are what the standard of care used to be. We took the standard of care.
Let me rephrase my question. There's a standard of care. Is there a way to incorporate that standard of care into these guidelines, referring to it? You can still call it what you want to call it.
You could do that, but it doesn't conform with the law anymore. That's the problem. That's why we created the guidelines out of the standard of care. When we passed AB 1308, we could no longer do breaches. We could no longer do twins. We could no longer do anybody that was before 37 weeks or greater than 42 weeks.
So why
And
not
we could
adjust?
no longer continue care even if the woman wanted us to. So those pieces got removed from the standard of care, and then we renamed it and called it guidelines.
I think what we're trying to understand is, can it just be the same document?
No.
Okay, it cannot. And I think you're sitting there because we can't post or make public the standard of care.
I'm not really sure what the mechanism was or how that got pulled off the website, because it did used to be there with that regulation. You could access it, but you can't any longer.
Okay, so your recommendation is you want to see the standard of care become available to the public, and in place of the guidelines, even though you...
No.
She wants the guidelines off the
I
website.
want the guidelines
Right.
gone.
I got
There
it.
is no longer regulatory authority
They're
to create
obsolete.
the standard of care.
The guidelines are obsolete. That is really what you're trying to say.
They are obsolete for many reasons, yes.
That you don't have to be more, you've been so detailed, and I thank you
They're-
for that. I just for
they
the sake of time,
Yeah.
yeah, you've answered all my questions.
You sure?
I am.
Okay.
Thank
If you
you.
think of another one, I'm still here.
Okay.
Carrie, can we just pull them off the website?
They're right here.
That would have to go through board approval because it went through board approval to get them posted.
I don't
Okay,
think it did.
so in order to do that, we'd have to put it on the agenda for the next medical board meeting.
Right.
Okay.
Same with revisions. That would have to have board approval as well.
Anybody have any other questions of me? If you want to email me, I'll send you a copy of the standard of care, and then, but you have it.
Yeah, no, thank
No,
you.
you just have the guidelines.
Okay.
You don't have the original standard of care. You just have the guidelines there that have all the strike-throughs as part of your packet.
Thank you for all your work on this, Carrie.
Faith Gibson, and I was at the MAC meeting on December the 4th, 2013, when there was the discussion about, actually, we didn't know when AB 1308 was first passed and signed by the governor, neither the medical board nor the midwives realized that it repealed our standard of care. We learned that at that December 4th meeting when Kurt Warden announced that that was the fact and they would be taking them down, and the midwives all went, "Oh no, you can't do that," or many of them did anyway. And he said, "Well, would you like for us to leave them up as a justice practice guidelines?" And he was very specific about that they would not defend a midwife, that a midwife could not point to them and say, "I did what it said there, and that's my defense." Nor could someone point to the practice as guidelines and no longer as a standard of care. They could not use that in a disciplinary action. So I didn't realize, I thought that was just done, that he just went and did it, but Carrie said no, that it was looked at by the board. The other thing with the VBAC issue, the VBAC controversy, which went along with the passage of the original standard of care, and I want to make a really important point here, that the standard of care and the practice guidelines are actually kind of like two halves of this 14-page document, the original standard of care for California licensed midwives. The standard of care is typically has to do with what you and I might think is the ethics of professional practice, and that includes part of those ethics of professional practice. Included, this is what's been removed from the practice guidelines as the practice guidelines. It's pretty short. Let me just read it to you. Risk factors identified during the initial interview or arising during the course of care. Responsibility of the midwife with respect to the care of a client with a significant risk factor is identified by the client selection criteria, which is the immediate page before that. In Section 4 or other science-based parameters, the licensed midwife shall inform the client about the known material risks and benefits of continuing with midwifery care relative to the identified risk factor, and shall recommend to the client that her situation be evaluated by a medical practitioner, and if appropriate, to transfer her primary care to a licensed physician who has training and practice in obstetrics. Now, the client's rights of self-determination, which these two have to go together to make sense. In recognition of the client's right to refuse that recommendation, in other words, the evaluation by the physician, as well as other risk reduction measures and medical procedures, the client may, after having been fully informed about the nature of the risk and the specific risk reduction measures available to her, make a written, informed refusal. If the licensed midwife appropriately documents the informed refusal in the client's midwifery record, the licensed midwife may continue to provide midwifery care to the client consistent with the evidence-based practice as identified in this document and in the scientific literature. So originally, all of these, that is followed by these guidelines that have to do with client selection, antepartum, intrapartum, postpartum, neonatal, with the possible exception of the neonate who can't give consent one way or the other. Those all had as a kind of modulating effect that the client could decline, and we were still authorized to continue to provide care. That the standard one of the things that the original one says, and actually this would still be on the because they were just renamed. Those sections were taken out. There were some other strikeouts, but it's the same document with a different header. But this one says, however, the standard of care is not intended to replace the clinical judgment of the licensed midwife. So our standard of care, as passed by the medical board in November of 2005, as accepted by them and as passed by the Office of Administrative Law in March of 2006, permitted midwives to, required midwives to give all of the information, and then permitted the midwife in circumstances where that was a reasonable choice, and VBAC is one of those instances, post dates where the mothers had, she's had a non-stress test and it's fine, that kind of stuff, was part of our standard of care, if you use that word loosely, as opposed to the technical thing, which is standard of care with legal consequences versus practice guidelines, of which there is that is a guideline, and you can have extenuating circumstances for why you didn't do that. I also want you to know that because the original standard of care, what we lost with the removal of it was that page that I just read to you, and the other thing that we lost with the removal of it was the California Code Section 1379.19, which was all of those lists of things having to do with it was called the VBAC compromise. That if we gave the client a copy of ACOG's own policies about VBAC, which very explicitly say you should have your baby in the hospital. We had to physically give the mother a copy of that. We had to tell the mother what our experience and background and training was for VBAC. We had to provide fully informed consent. The mother had to agree to be monitored more closely instead of maybe heart tones every half hour, every 20 minutes, instead of every 15 minutes, every 10, that kind of thing. And she had to agree, the family had to agree to go to the hospital if in the clinical judgment of the midwife, that was the appropriate thing to do. There are people, myself being one of them, I've talked to 2 people on the members of the medical board that are talking about going back and putting this all back in there like it was before, like it was prior to AB 213, so that we would again have the VBAC compromise, and we would again have a standard of care and standards of practice which allowed both the midwife and the mother to make exceptions to the guidelines. That it still is a good idea, I think, have always done this, to say to people, my recommendation is that you at least talk to a doctor about this before you decide. And then I have people who say, I did that last time. They have Hashimoto's disease. This is their 3rd pregnancy. He didn't do anything last time. I'm not going back and doing that again. I think I know that worked for me. It worked for all the midwives in my peer review group. When I talked to people, other midwives around the state, that pretty much worked for us because it was not it didn't lock us in. I brought this out if anybody actually wants to see this.
Oh, thank you. So, Faye, what I hear you saying is you think there should be some flexibility?
Well,
thank you for the summary.
Let me say this about it, because Carrie and I do differ in how we look at this, is that to say, well, doctors don't have that is, that's true, but we also aren't doctors. And there's a lot of political and other stuff going on kind of behind the scenes about midwifery that makes it kind of problematic. And I think having a standard of care is a little bit like the difference between driving a car on a road with no posted speed limit, and they can give you a ticket for going 5 miles an hour because there's no limits, versus one that has a speed limit that says 35 miles an hour. And if you're going less than that, you can't be ticketed for speeding. So again, along with the fact that the mother has the right, that we have the responsibility to give her all the information, and after that she has the right. We also, part of the Licensed Midwifery Practice Act, a really big part that, right up at the top, right when you very begin to read it, our standard of care has always included that if there is a complication, now, it doesn't say serious complication, so I guess it could be a little loosey-goosey as to, what is a complication. But in my book and in most textbooks, it says a complication is something that could really, that if left unaddressed, will result in harm to the patient. If there's a complication, we have to transfer that mother to the care of a physician. It doesn't say, I think it does say immediately, but it doesn't define immediately.
Thank you. I feel like it's too detailed for me right
Okay.
now, but I appreciate the detail. I think we kind of have enough information. I hear what you're saying. You have a different angle. You see there's some benefits from...
I see a benefit
Okay.
in having a standard of care that includes the responsibility of the midwife to inform and the right of the mother to decline.
Thank you.
That would take care of the VBAC issue all by itself, along with the 42-week issue, along with a lot of other things. Thank you so much. I'm a talker, so I apologize.
I am obligated to remind everyone that AB 1308 made significant changes to that, and there is not an option now for the woman to have informed consent and to waive the referral to the physician. So that would require a statutory change. I think that was part of this compromise in removing physician supervision.
Yeah, I just want to say that's what we were talking about. We were talking about legislation. We're not talking about them, just changing the title or anything.
Are there any questions or comments from the board, from the MAC? Any other comments in the audience? No. All right, so we will, I will get with you and we'll figure out how to exactly put this on the agenda for next time, which proposal we want to put on. And we will now move to agenda item number 10, the program update with Ms. Moriarty.
Please turn to tab 10A1 of the packet for the midwifery program licensing statistics. In the second quarter of the fiscal year 2019-2020, the board received 12 new applications, issued 9 new licenses, and renewed 64 licenses. As of January 1st, 2020, there were 436 renewed and current midwifery licenses. Please turn to page 10B1. In the second quarter of the fiscal year 2019-2020, the board received 45 transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. Please turn to page 10C1 for enforcement statistics for licensed midwives. In the second quarter, the board received 8 complaints and 2 were referred for investigation. Please turn to page 10C2. The board received 2 complaints in the second quarter of 2019-2020 for unlicensed midwives. And please turn to page 10C3 for enforcement statistics for transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. In the second quarter of 2019-2020 fiscal year, 1 was referred for investigation. And please turn to page 10C4 for the second quarter of the 2019-2020 fiscal year. The board received 2 transfer planned out-of-hospital delivery to hospital reporting forms for unlicensed midwives. Any questions?
I just am curious, and maybe nobody actually knows the answer, but I know that when you get the transfer care reporting forms for licensed midwives, they're kind of treated as a complaint. We've kind of been through that. What happens when they come in on unlicensed midwives? They must also then be treated as a complaint. And if they're not licensed, they're not legal. So does that then trigger an investigation of that person who's an unlicensed midwife transferring to a hospital? Just curious.
I don't know. Does anyone here know the answer to that question? I know, but I know that this one, I believe that the one or the 2 that were reported were actually certified nurse midwives, right? They're categorized under unlicensed midwives.
No,
Isn't that what it
unlicensed.
It says on the bottom, transfer reporting reforms reserved for nurse midwives are included under unlicensed midwives. So it looks like the 2 that were received were actually nurse midwives?
How would you know?
Are you referring to 10C4?
10C, yes.
Because on another page, on a different page, it actually had forms that were received on CNNs. Anyway. I'm hoping that the board is making sure that unlicensed midwives are not providing care as much as they possibly can.
Any other questions or comments from members of the MAC? Any from the audience? Seeing none, we can move to agenda item number 11. Discussion on how the MAC will prepare for future fall board meetings when legislation is proposed. And we put this on last time just to discuss whether we think we need to move our fall, a meeting closer to the fall board meeting. That's why we did this. But, you know, the reality of it is that it can't be just because of the amount of work that staff has to do in order to prepare for their fall board meeting. It can't be super close. It has to be at least a month away, right? Wouldn't you say, for you guys to have time to do that? So there's still a month in there. So does it make sense for us to move our meeting closer, which would be, I guess it would make it, what, a month or so later than August? So we could think about doing it in September, perhaps, October.
Correct me if I'm wrong, but you can't really set a date for the next meeting today, right?
No, we can't, but we can discuss, the whole issue was about whether it needed to be closer or not. And if we decide it doesn't need to be, then we just go back to choosing the dates next meeting.
I'm sorry, when is the fall meeting for the medical board?
It's our last meeting, I believe, is August. We have a choice of August.
Not our meetings, the medical board's meeting.
Oh, the medical board meeting, November.
November 12th, 13th.
So I'm not sure if we can or if there's any will to do it, but I still think it is a good idea because there's just every single barrier I feel exists intentionally for midwives to have a voice and consumers that use midwifery care. So this all came about because of the legislation that was proposed that was directly a midwifery issue, but there was no consultation with the Midwifery Advisory Council. And so I think we were saying, well, how could that be avoided? Because it was, if, people hadn't read the public agenda and then, recruited people to go and to give voice, then nothing would have happened because that is clear that thank you guys for coming out today. We really don't need your report. That's how they set their agenda. So I just want to be clear, the point of this is a strategy to be working with them, which I think is why this was designed, so we can work together. Mm-hmm. So I don't have hope that we could really move the meeting, but I still think it's an important conversation. It's an important point. I think it's important to say that we are a player at the table, and how can we make that working together functional? So it's not that we find out something October 30th, and then we have to, tell people go to the board meeting. That just didn't seem right.
When does the agenda for the medical board meeting come out for the November meeting?
It's at least 10 days ahead of time.
10 days, at least 10 days ahead of time. Okay. So November 13th. So 10 days ahead of that would be November 1st for this meeting anyway.
I just would like to give a little input. Sometimes the board doesn't know until they are right on publishing the agenda what's actually going to be on the agenda because there's so many moving parts. And I think what Ms. Abe is saying in terms of trying to create some cohesiveness with the actual board so that if they're going to be discussing midwifery related issues, that maybe those issues could be hashed out in the MAC first before they appear in front of the board. But that's something you guys are going to have to work with staff and with the board on so that this kind of thing doesn't happen again. But moving the MAC meeting is not going to be helpful. I mean, it's not going to get you the results you want because the board isn't required to post an agenda sooner than 10 days before their meeting. And I'm not saying this is the case, but if they don't want to work with you on a particular thing, they don't have to. So you got to somehow build that alliance where the board sees the value of bringing midwifery issues through the Midwifery Advisory Council before they come to the board.
But I think that's the point. There's no will, or there's little will. So, yeah, that's a good conversation to have. It's almost like an afterthought that we're just even here.
But I guess the question is, will moving the meeting actually remedy any of that? Probably it won't.
I tell you, I think it would be good PR, but I don't know because of the staff. Like if it sounds like October, it still couldn't happen in October.
Well, I'd have to ask staff how much lead time they would need, because that would be preparing for a MAC and preparing for the they probably need at least a month for the medical board meeting to prepare it. I don't really know. How much time do you need?
And you also have to then consider the distance between the March meeting and the next meeting, because that's significant too when you're working on task forces and you want to get things accomplished. You don't want to put your next meeting from March 6 or 7 months out just to try to accommodate something that you're not going to accommodate in the first place. It's just not. It's already from March to August is 5 months.
Well, there's a December meeting in there too, right?
And there's December, which is 3 months. So you have December, and then 3 months later you have March, and then there's 5 months to August, and then there's another 4 months till you get back to December again. So moving that August meeting into late September or October means that you've got a really long gap between March and that next meeting for any kind of work that's going on with task forces or committees, and you're not gonna achieve what you want anyways.
I think you should make your public comment. One public comment per person on agenda item will help us.
I have the question. We can't just pick a day for a meeting. There has to be availability. So, am I correct? Can we just pick a day for a meeting?
There has to be the hearing room available.
Right.
And so
Right,
typically what staff does is provide 2 date options for the MAC members to vote on.
So is there availability in the beginning of October the end of October or beginning of November? Because if there's no availability, then we're just talking for no reason.
I mean, I can tell you that is not realistic for staff. And so, realistically, you're looking at an August or September MAC meeting.
But I don't think we even have dates for September right now.
We don't have.
They're not in the packet. We just actually have the same dates that we had at the last meeting,
Right.
which is disappointing because it's not. This conversation is futile because there's not like, oh, this date would be available, right? So this was just to make a point, and I think people were very upset last meeting, so that's why we put this on the agenda, and now everyone's over it, really. So, it's good I think it's important to talk about things, even if there is no solution.
I think there's also the matter of being able to put something on the agenda and who can put something on the agenda. If there is an individual who wants to put something on the agenda that is oppositional to midwifery practice, they can do that, and there's nothing we can do to stop them. So I guess that's and I think that's what that proposal for regulation was, and I don't think that's something that would have come before this committee. I think it was something that tried to slip through, and I don't think we can stop them from trying to slip through. I think what we can do, the only thing we can do, is be vigilant to see what is on the agenda of those meetings.
That's probably true, but I think that's kind of awkward, and I don't have the right word, but I would also say sad, because this is a midwifery advisory council with the word advisory.
Correct.
So the intent, if you never were a part, you would think from the public, the midwifery advisory council meets and discusses things for what's in the consumer's best interest. And when they make their report to the medical board, it's not an afterthought that what we discussed here is really weighed and so forth and so on, but it doesn't seem to be the case.
Well, our barriers to the regulation that has been worked on for so many years is, in my opinion, primarily one organization, and that's ACOG. They won't agree. It's not the MAC. It's members of ACOG. It's ACOG, and they're oppositional. I don't think there's anything we can do about that in this setting.
You mean as the MAC, there's nothing we can do?
Correct.
I know, but the MAC exists, so people just feel like the last lady came here and cried, and she was so, people think we have some powers.
More than we have.
Yeah, absolutely. Absolutely. And it's, so you have to demystify it, and at the end of the day, that whole thing about can we change a meeting was to see what can we do, but it's clear that we can't even set a meeting sometimes, so.
Well, I think our time would be better spent working on things like the guidelines or standard of care and other issues than trying to circumvent the MAC from being underhand, or not the MAC, but individuals from being underhand.
All right. Are there any other comments?
I'm sorry, I have one more.
Sure.
Do we have a date for our next meeting set?
We can't set it because we don't have a quorum.
So what does that?
We don't meet.
What does that mean?
That means we'll have to do something like a doodle poll to set the next meeting and get availability.
Okay. So we will have the next meeting.
Oh, yeah, this isn't the.
But it won't be voted on. Okay. Yeah.
So we can do it in the interim by polling all the members, is that?
Yeah.
Okay.
The proposed dates will be put out, and typically it's done through a doodle poll, and then where we see we can get a quorum and hopefully extra, we'll try to move forward with that date.
Great. And I think we're just going to assume then that it's going to be sometime in August, since we can't really change it at this meeting. So we'll get a date then. All right, then we're going to move on to agenda item 12, discussion and possible action on selection of a Midwifery Advisory Council member.
In January, the medical board posted a recruitment announcement on its website for one licensed midwife position on the Midwifery Advisory Council. The position is for a 3-year term that will become effective June 30th, 2020 and expires June 30th, 2023. The board received 3 applications for the vacant licensed midwife position on the MAC. The applicants are Faith Gibson, Tisa Curran, and Madeline Weisner. The 3 applicants were invited to this meeting. All applicants present today have the opportunity to introduce themselves to the MAC and provide a brief statement. Ms. Gibson, would you like to provide a statement?
I started my life in midwifery politics, serving on a midwifery advisory council in Governor Brown's first administration in 1980. So, if I were reappointed again, this would be my 3rd time round. When we were working with the legislation relative to having a midwifery advisory council, it was to have a way for us to communicate with the medical board. Prior to the midwifery council, what happened is you would come to a medical board meeting and you'd have to wait for public comments, and then you could get up and talk about something that was happening relative to licensed midwifery, which seemed not very appropriate for a profession that was that was regulated by the medical board. The statutes that we got didn't quite do what I had expected it to do, because, as you've noted, there's this thing where we have to kind of get our agenda items approved before we can, or our topics approved before they can become agenda items, which is a kind of an awkward way to do business. As you probably have figured out, I am just chock full of ideas about how to make midwifery work better for mothers and babies. I do want to say that if I had to choose between being an advocate for childbearing women and being a midwife, I would choose being an advocate if I had to choose. That during the years that I was a labor and delivery room nurse, which was a long, long, long time ago, when mothers were given twilight sleep drugs and general anesthesia for birth and big episiotomies and forceps and manual removal of the placenta, and were, unconscious for hours the whole time that they were giving birth. I was always I got fired a lot, actually. I was always trying to change that system and make childbirth work for healthy childbearing women, including the fact that I didn't want my daughters. I actually wound up having my first baby in the back seat of a Renault on the way to the hospital, as the only way that you could avoid twilight sleep drugs and forceps and the like. I didn't want my daughters or my granddaughters or my son's wives to have to do that. It is better now. We're not doing that, but we have a 33% cesarean section rate. The good news is that ACOG has come out. It's opinion number 766. Anyone on the video, you should go to the internet and look that up. They're actually talking about how can we reduce the use, the routine use of interventions. And if you read it carefully, it actually is the midwifery model of care. It's just they never say the M word. They talk about doulas and they talk about a lot of good ideas, but they talk about the woman's right to choose, as a matter of fact. Very, very interesting that they, that she doesn't have to have an episiotomy as long as you, make her knowledgeable of what might go wrong if she didn't, or IV or induction or whatever the issue happens to be. So I would like to see the Midwifery Advisory Council be kind of proactive, and I'm not 100% certain that is possible. One of the reasons that I resigned in 2013 was I was interested in doing some legislative work, and I felt like it might be a conflict, between myself and the board to have me be on the board, the Midwifery Council. To be on the council and be pursuing everything about midwifery is politically charged, especially legislation. So I don't know 100% for certain. I do know for sure I'm going to keep on being politically active. I believe I have a lot to bring to the table having to do with the Midwifery Advisory Council. I actually have books for each of you, as a matter of fact. I just figured you didn't have enough to read at home, and so I brought you a little something to read. Anyway, do you have any questions? Anybody got a... Okay, thank you very much.
Thank you. Ms. Curran, would you like to provide a statement?
I'll just make a quick correction. It's Kareen. Thank you. So I'm Tisa Kareen. I'm representing, well, what I would like to be well known is that I'm from Southern California, which I see a lot of people from this part of the state sitting here today. There are a lot of people from Southern California that feel misrepresented up here. I want you to know that I am a fairly new midwife. I have 5 years, and this is my second career. I was in the United States Air Force for 10 years and decided to become a midwife after really no bad outcomes in my own personal life. I gave birth to 5 babies in the hospital and one as a home birth, but just more out of advocacy because of our state of maternal health in the United States. And from that has pretty much driven how I have grown as a midwife, which led me into Medi-Cal, being a Medi-Cal provider and kind of being really on the floor, like on the ground with that. My application was submitted over 2 years ago, and it took almost a year for it to be approved, which is crazy. and it was very, it was very trying. And I think that there's a lot of midwives in the state of California that are really wondering, like, what is the direction for us to really grow? This being 2020, the year of the nurse and the midwife, this would be a great opportunity for us to really start talking about integration, which is what I'm really passionate about. I saw the numbers that were reported earlier today about births. There was only 159 VBACs out of hospital, which is a really small number, in my opinion, when there are over 9,000 babies born in, what'd you say, a week in the state of California, in a whole year. So yes, midwives are fantastic, but we need more numbers, and we need to really start integrating into the system to really make an impact in maternal health. And this is what I've really been passionate about, as I have tried really hard to integrate myself into our own community down in LA County, becoming a part of a federally qualified health center. And I work there 1 day a week alongside nurse practitioners, OBs, and CNMs. Also providing care to people who are having hospital births, not just women or people who are planning to have out-of-hospital births. So I'm providing primary care, sorry, is that too close? Providing primary care for people who are going to have hospital births as well, which has really become, I hope it becomes a model for other midwives to look at. How can we work collaboratively in our communities with the medical model? How can we help people have better care during their pregnancies, in turn having better outcomes with their hospital births, correct? And then just the medical aspect. I have a real invested interest, as 80% of my clientele are Medi-Cal today. So I would definitely have I would like to be a part of the Medi-Cal task force in one way or another, to really keep that on the forefront and making sure that we're pushing forward with that. Any questions? Thank you.
Thank you.
Thank you. Ms. Weisner, would you like to provide a statement?
Hey there, I'm Madeline Weisner. I love talking about myself. Anyone who knows me knows that I love talking about myself. But it seems like that isn't the job here. It seems like the Midwifery Advisory Council is here to listen and to facilitate and to facilitate the actual stakeholders in maternity care and midwifery care in California, right? And work as a communication tool between those stakeholders, mothers, babies, midwives, between them and between the medical board, and make reasonable demands to the medical board. And I'm hearing you all talk about how there's not a lot of power in the MAC and can't really get a lot done or whatever, but making those reasonable demands to the medical board is really, really powerful, because it's showing that they're not meeting reasonable demands. So I'm really interested in helping with that and helping kind of broaden that level of communication, both with the medical board and with the stakeholders. We have reasonable demands here. They're not being met. We need something different to happen, and then really harnessing the power of the stakeholders to make that happen. So happy to help with that. Thanks for listening. You can read more about me in the documents I submitted.
Thanks.
Thank you.
Are there any comments from the MAC members? Questions?
We have to table this till the next meeting, right?
Yes, yeah, we do.
But is this closed, or can other people come in to the next meeting and give a statement?
That's a good question.
It is closed in the sense the application deadline has already passed.
Oh, so do they have to come back again, or we have enough information now to vote next time?
They don't have to come at all. It's always recommended that applicants do come. They wouldn't have to come again. And so I know that it involves travel to get here, some from great distance. So,
But we won't be doing presentations again, right?
no, but they could,
They could.
give
Okay.
public comment. I mean,
Okay, right.
And would we be able to, is there a way to broadcast what they just shared?
It's recorded.
I know it's recorded, but would it be able to be broadcast at the next meeting?
the members who missed it would be able to view it on the
Oh, at their
webcast.
own leisure. Okay.
Any other comments? Carrie?
I just have a technical question. Since there are now term limits for the MAC, how does that affect somebody reapplying? Because I assume, that I can't reapply because clearly I used up all my time, and I'm just wondering what the answer is to that.
That's a good question.
Yeah, I was looking at that because there is a Business and Professions Code section on maximum number of terms that said no member, and this is the brief version, shall serve more than 2 consecutive full terms. So I need to double check whether that's a bar if there's a gap.
Yeah,
Um,
doesn't really answer
right. Does it? So I was thinking about that, and I will double check that.
Any other comments, questions? Great. So, I really would like to take this time as well to acknowledge and thank Ms. Perez for her service to the MAC. This would have been her last MAC meeting today, but I guess she had her last MAC meeting last time. But I just want to publicly acknowledge that she was here and served and did a good job. So moving to agenda item number 14, because we're not going to do the dates, right? Right.
You should.
We're going to agenda item 14 to future agenda items. We can we do that?
Just say 13 is being tabled because there's not a quorum to be able to select dates.
Right, okay. Yeah, moving to agenda item 13 is tabled because we don't have a quorum to select dates at this time. That will happen in the interval. And then agenda item number 14, future agenda items. We will have to reappoint members to the Medi-Cal Task Force. Establishing goals as a standing agenda item. We'll have another report from the task force and discussion about the LMAR, the adding demographic information. We will have another discussion and possible action on revisions or removal of the practice guidelines for California midwives. we will have a discussion and action on selection of our midwifery advisory council member, and discussion on future MAC meeting dates. Rosanna, would you be willing to be on the agenda for your suggestion about using the presentation and education about midwives from CALM, taking it to the medical board, doing something like that? Would you be interested in? I can work with you on however you'd like to present it.
So how does that work?
Well, your suggestion was that you would like the MAC to advocate for the presentation that CALM, tell me if I'm right, that the presentation that CALM developed, and take it to the medical board. And
Yeah, I'd like to ask the medical board to partner with the community at large, CALM, other stakeholders for quality improvement on transfers. Yes. Is that so?
With the presentation on the smooth transitions, how it would work and how it would be implemented in the state
Yeah,
here?
maybe we start with
So that we can see what it is, so that we
presenting
can make a recommendation.
presenting the template here to start with.
maybe that's the way.
And then
that's the
move.
way to do it.
I think that would be a good idea if we discuss how it could potentially be implemented and how the medical board would exactly be involved, so that they don't have to come up with something. It's just, this is one way we think would be good for you to do. And then I think it'd be easier to be adopted or accepted, rather than say, we want you to partner with us, and they say, okay, yes, but then what? Or there's not enough information to know whether we should do that. But I think to know more specifically what their role would be.
Is it developed to a place where you could bring some kind of a template for a presentation next meeting, or?
Yeah, I could do that.
Okay. All right.
Thanks. If you can give me a date.
August 20th.
And then Faith would like to talk to us about, this is a legislative thing, though. I don't know. Do you still want us to talk about this, Faith, about extending the postpartum period to a year?
Yeah.
Okay. Did I get it all? I think I did.
Diane,
And of course, the
seeking extension of the standard of care to include up to 1 year, and we're still also discussing possible action revision to the practice guidelines. Are those related enough to consider them as one discussion? We're talking about seeking an extension of the standard of care, which the board really doesn't regulate, right?
Mm-hmm. Well,
But
Carrie's thing is to take them off the website, right? Is to take the guidelines off the website now.
Well, I'm speaking specifically of Faith Gibson's suggestion to seek extension of the standard of care to
I
include.
think she's talking about a scope expansion, and that requires a legislative change. That's different from the guidelines that are posted.
Okay. Okay.
I think I got it. And we program update, obviously, we'll have that in there too. And do we still have the licensing updates are involved in the program update, right? Yeah, okay. I think we got it all. I think we did it. Oh.
I probably should have said this in public comments, but CALM has not been able to identify an author for a bill that would fix the regulatory stalemate and other issues that we thought would be long-term solution. So I know the So if you all remember, the medical board actually approved language that was a compromise to fix the regulatory stalemate. So I would like to request that we ask the medical board if they would consider working with the midwives on a statute to fix it in the interim.
To fix the stalemate.
I don't know what the,
Okay, so how do we word that? Discussion on a presentation to bring to the medical board requesting,
oh, it has to be a presentation. Okay.
well, it doesn't have to be a presentation, it could be a discussion of
I
it.
mean,
I mean, we
the-
have to bring it to the medical board somehow.
The way it unfolded before was that there was a midwifery task force comprised of 2 medical board members, and we had interested parties meeting, and some language came out of that.
Okay, so a request to the medical board for an interested parties meeting.
Is this an agenda item we're talking about?
Yeah, and we have to ask the medical board
We're asking.
to approve it, so.
So this is a future agenda item.
Exactly,
For this.
exactly. I'll figure out a way to work it, but we'll discuss a proposal to the medical board to try and fix the stalemate. I'll come up with better words. Any other agenda items? All right, then I guess the meeting's adjourned.